Okay, everybody ready? Yep. I'm going to hit start broadcast. Hi, everybody. This is Alyssa Terry, and I am working with NYMAC on the Telegenetics Community of Practice. Thank you all for joining us for the second webinar. Some housekeeping issues to start off. First, remember to sign up for NYMAC's Basecamp system. This is where we post the recorded webinars and resources, and you can also ask questions of your other TCOP members. We'll send out an email reminder about that soon. We encourage you to invite your colleagues to sign up too. Once you're signed up in Basecamp, you can invite your colleagues. Our next webinar will be on December 13th at noon, and we'll focus on conducting a needs assessment. You can direct any questions about the TCOP to Beth Vogel or Kunal Sanghavi. And you can find NYMAC on Facebook also for other updates. So today we are focused on care coordination, and this was ranked #1 in terms of area of interest for education in our telegenetics provider survey. You know, we all know that care coordination for our genetics patients is a complex challenge to begin with, and using telehealth forces us to change the way we approach it. Clearly, the patient is no longer physically with us, and also more so than usual, we may be working across multiple healthcare systems to help the patient. However, at the same time, telegenetics presents these new care coordination challenges. Our new technology may also offer some novel and exciting solutions to improve care coordination. So with that in mind, I'm so happy that Bonnie Britton is here with us today. As I shared in the webinar announcement, Bonnie is a recognized telehealth expert, partner to the Mid-Atlantic Telehealth Resource Center, and owner of Reconnect for Health. She has dedicated the past 18 years of her career as a nurse, advancing the adoption and implementation of telehealth both nationally and internationally. Bonnie has held numerous important positions in the American Telemedicine Association and has provided expertise to groups including the United Nations and the U.S. Senate. Bonnie founded Reconnect for Health in 2015 to provide patient-centered remote monitoring for patients with chronic conditions who are high risk, high cost, and vulnerable. We're looking forward to learning from her expertise, and Bonnie and I are both hoping that you will share your care coordination challenges and successes with us today so that we can discuss them together. So Bonnie, you can go ahead and take it from here.
Okay, Elise, thank you so much for that kind introduction. I'm really glad to be here to speak with you, and can you hear me okay? Okay.
I can. I think everybody else is on mute, but I can hear you great.
Awesome, great. So if you could advance the slides. As Alicia said, I've now been working in remote patient monitoring and remote monitoring for the past 19.5 years. And the thing that still surprises me so much is the nomenclature is so confused. It just, every day people use the following: telehealth, telemedicine, remote monitoring, wearables, sensors, mHealth, all interchangeably. And so I really wanted to start with, in the beginning, is to help everyone understand within the industry the distinctions between some of these terms. Because, and you can advance to the next slide. Because for an example, in the beginning of telemedicine, many, many years ago, everybody considered everything to be telemedicine. And telemedicine is actually when you have a clinician that is connected to a patient in another clinical setting that is being presented. A model, it's a hub and spoke model, usually carrying T1 lines or broadband lines for high resolution camera, as well as peripherals such as stethoscopes, audioscopes, etc. So when you think about telemedicine, that's really, yeah.
Just every once in a while, your voice is going in and out a little bit. I don't know if there's anything we can do about that, but for the most part, I can hear you, but every once in a while, you go in and out a little bit.
Okay, I'm moving forward right over. If it happens again, please interrupt me.
Okay.
So, as I was saying, telemedicine is really a hub and spoke broadband type application. Remote monitoring really looks at the remote collection of and review of patients' data, whether that's their weight, their blood pressure, their oxygen saturation, their blood sugar, etc., so that patients with chronic illness and patients who are at the greatest risk for readmission, including those patients who are non-adherent, really benefit dramatically from remote monitoring. And then when you talk about mHealth, you think about the patient being mobile. So telemedicine is really based in the clinic. Remote monitoring is based normally in the home, assisted living facilities, etc. And then telehealth really implies mobility. So that may be doing telemedicine and remote monitoring through tablets or smartphones. And that also mean now doing video connections, HIPAA secure video connections through tablets, computers, and smartphones with patients on the go. So if you wanted to, for an example, I'm working with an organization and they're going to be using video to be able to conduct pre-employment screenings, so to do it at a remote distance, as well as working with folks who are using video conferencing in patients' homes for cancer patients who have complex medical needs, coordination, symptom management, etc. And then the non-clinical application are wearables, sensors, and health apps. There are so many health apps out there. There's no really good way to validate the clinical appropriateness and outcome from these apps at this time. There will be more and more sensors. I've been introduced to some companies that now have sensors that you can place on a pregnant lady's tummy and be able to obtain the heart rate and the temperature of the baby. So lots of exciting things coming in the future. Next. The different platforms, I'm sure you know all of this, but it can be done through a phone line, plain old telephone system, cellular connectivity, Wi-Fi, and of course tablets or smartphones. The one thing I really want to say about modes of transmission is you really need to understand your population that you're working with and how they connect. You may have patients, the majority to be cellular, smartphone and tablet ready, but you may also have patient populations who do not have landline phones anymore. They may have a cellular coverage, and you also need to understand your cellular coverage area, because every cellular company doesn't work in every area. That may be better for your region than it is in rural North Carolina or rural Kentucky. But it's really important to understand that, because if you don't have a good understanding of that, then you may be selecting technology that's not going to meet your patient need. Everyone now has encryption and cloud storage. That's pretty universal across the industry. And most companies have FDA-approved biometric devices. And this is just a list of 4. There's many, many more. And as you move forward, if you're interested in some of the companies that provide these, I certainly, I'm totally vendor agnostic, but can help you with that. And then one of the most important things is, historically, most organizations really spend their time on focusing on the hardware and really don't focus on the software and what analytics are built into that software for you to be able to evaluate your program, scale your program, and easily track patients. And then also the ability for data analytics. Next slide. In speaking with Alicia, we have spoken several times. In the beginning, this was difficult for me to get my arms around, because as a nurse and have spent the last 19 and a half years working with remote monitoring and care coordination, I couldn't quite figure out what was unique about your situation. But through some very good conversation, I believe I understand what your barriers are for your care coordination. And I just wanted to go through these and then open this up to have discussion about these barriers. And then following that, I will be providing some recommendations that I believe can help you overcome these barriers, and we'll open it up for discussion there as well. So one of the things that you're experiencing is you have multiple providers who may or may or may not know each other. You've got specialists, internal medicine, cardiologists, genetics. You know, you have so many specialists that your patients are working with, and one provider may not understand what the other provider is doing or what the capabilities are. You also have primary care providers that are involved with these patients along with the specialists, and then your multidisciplinary team, physical therapy, occupational therapy, etc. Then I'm under the assumption that you have multiple EHRs. And if you don't have multiple different electronic health records, I'm not sure if there's a lot of ability to communicate within other organizations' electronic health records. So that I see as a barrier. You have various telehealth infrastructures. Some of your organizations may have sound infrastructure with technology as well as modes of connectivity. You may have others that have basic and don't have the funds to expand. So that's another area where some organizations may come to the table and play and others may not. As we spoke earlier, you have very complex treatment and medical regimens. And so the ability to coordinate those activities I see as essential. There's a lack of knowledge of the genetic services that are available, so there's a need for education to primary care providers, other specialists about what you do, how it benefits the patient, and to have some low-cost video capabilities to be able to do that. You have a mobile patient population because you manage patients from birth through the age band. Next. There's a lack of infrastructure for in-home video visits. In-home video visits now, the platforms that can do that are extremely HIPAA secure, they're low cost, and it's a wonderful way to provide patient education, also to do an assessment of that patient. It's a good way for not only nurses and physicians to be able to educate and do assessments, but any member of a multidisciplinary team. For patients to be able to do that, all they need to have is a smartphone, a tablet, or a computer. Now, I know all of your patients will not have those capabilities, but with a mobile population, I'm thinking you will have a large number that would. The other thing is a lack of patient-centered care plans. Every electronic health record and every physician creates a treatment plan, but there's not a centralized patient-centered care plan that really looks at the goals and objectives that patient wants to achieve. And also a lack of ability to upload documents in a centralized HIPAA secure environment. So when we talk about recommendations, the lack of being able to upload documents either from the patient, who could upload documents after they've gone to a visit, their lab reports, it could be the specialist uploading a summary of the visit to anyone else within the system that needed that. And then you have decentralized scheduling of tests and appointments, and there's now software platforms that allow you to be able to, providers, to be able to block out times for visits or appointments for patients to come in, as well as the patient to be able to schedule those remotely. And then competing organizational priorities. Next slide. So before we get into the recommendations, Alyssa, could we open it up to see, number one, if anyone has any questions, and then number two, to discuss the barriers that we had identified and see if there's additional barriers that need to be included, or I may have some barriers that I listed that you don't see as barriers. So could we open that up, Alyssa?
Yep. Bonnie, do you know how to unmute everyone?
I do not, but if you...
No, Bonnie Frederick, do you know how to do it?
Sorry. Or if not, we can do it at the end.
I'm sorry, I don't.
Oh, wait, I think I found it. Okay, if you click on attendees, oh, where did it go? Do you see on your control panel on the side it says attendees somewhere? Why don't we keep going with the presentation and we'll figure out how to get people unmuted by to talk at the end.
I think I have it now.
Oh. All right, so everyone is unmuted now. If people have questions or comments to share, Bonnie would love to hear about the barriers that you have experienced in care coordination if people would like to share that. Does anyone have any thoughts? All right, Bonnie, why don't we keep going and we'll check back with people. Why don't we keep moving forward and we'll check back with everyone at the end.
Did we lose Bonnie? Do we have you back? Oh, Bonnie, I think we have Bonnie back. Okay,
yeah,
great.
Somebody unmuted, had put me on mute, and I couldn't figure out how to get back on, so I called in on the phone.
Oh, geez. Okay. So sorry. There's usually someone else running this, and they are not with us today. So I'm so sorry.
That's okay.
Let's proceed, and
okay.
we'll check back on others for discussion later. But let's keep moving.
Okay. So, in thinking about what your barriers were, really, here are my recommendations for discussion. Number one, you're going to need a HIPAA secure platform that is going to allow you to schedule and conduct video visits for specialty visits, in-home visits, specialty education, in-home education, and also in-home medication review. This portal platform would also be able to upload documents so that a patient or a physician or any clinic could upload test reports, consult notes, and they would only go to the specific people who need to see those. It's also platform to be able to message your patients related to needed community resources and secure messaging. Because a lot of things, you know, texting a patient is not HIPAA compliant unless you have an app on it to make it HIPAA compliant. And since your EHRs don't communicate to each other, I think having a single source platform that you can do all of these things on that can integrate with your electronic health records would help you to achieve some of your success. Next, please. Also, a platform, if you started looking for one, I would recommend it would have patient reminders and calendar applications. So the patients could go in and receive reminders. You have an appointment tomorrow, or you need to come into the office tomorrow to have blood drawn. It could be uploading a script for the patient to go get labs drawn locally and be able to upload those once they have the results. Calendar features for scheduling video visits. That can be done on demand or pre-scheduled. And then a way for a patient-centric care plan to be developed that can then be created and shared along with progress. The other thing is patients are not sedentary. They're mobile. They're in the hospital. They're discharged from the hospital. They're enrolled into home health. They're given an appointment at a specialist office, a primary care provider, etc. So it's very difficult currently for you to know where your patient is and where they are along their clinical plan. And then the other thing is, since you have multiple EHRs, if you could find a platform that has API integration with view-only options for any team member, and that would be specific for their patient population, I think would give you the infrastructure from a software perspective to be able to move forward. Not knowing all of the technical capabilities that currently exist there at the various organizations, I did not make recommendations for traditional telemedicine-based companies and solutions. If that's something you're interested in having, then I certainly can provide you with a list, because there's a lot of them out there. And so they really all say they can do the same thing, but what I've focused on here today, I really think are the things that would make you successful and could really become a regional model of care. Next. Other things that you might want to look at are medication reminders. I don't know how familiar you are with the following two med reminders. The second one, Choice in Med, is looks like a Fitbit that you wear, and you program in the software the patient's medications and the time that they're supposed to take them, and then this vibrates when it's time for them to use it. It is very inexpensive. I believe it's $19.95 for a patient to have. The downside of that is for very complex medical regimens, it really would not meet your needs. But for patients who have to take medications at a certain time and be reminded, it is a low-cost option. Whereas if you're looking at a device that can work with multiple medication regimens, there's a new company called PharmRight, and they have what's called the Livy, and it looks like a Keurig coffee maker. It sits on the patient's counter. It holds up to 15 medications for 90 days. And the best thing about it is once it's programmed and you insert the medications in the first time, it has what's called a Livy sizer. So it actually measures the size of that medication. So in the future, if the wrong meds put in that device, it will not dispense it. The other really neat thing is that in order to change a patient's medication dose, you simply go in and change the how many pills are going to be dispensed. So let's say your patient's on a regimen, they're taking a pill 3 times a day, and do you want to increase that or decrease that to 2 times a day or 1 time a day, twice a week? You can actually do that in the software. So it's very enhanced. It's very reasonable priced for patients who have very complex regimens. Other things that you may want to look at are health assessment surveys. These can be apps, or they can upload or complete health assessment surveys in a secure portal. And then the last thing, and not least in my heart, is remote patient monitoring for those patients who may have issues with cardiovascular, diabetes, chronic illnesses, or this has really been proven to be powerful for monitoring patients' blood pressure, their pulse, weight, oxygen, as well as glucose reading. Next. So that's the end of my presentation right here at 30 minutes. So I want to open it up to the group now to talk about what are your greatest challenges you and your patients face, and what strategies have you deployed, and really just open it up for conversation and brainstorming.
Great. Thank you so much, Bonnie. I'm not sure how we have done with getting people off mute, but I hope people can see. If they can't talk, I hope they can see on the side where you can enter a chat or a question. You can type it in, and I would be happy to read those, but we would love to hear from anybody that has questions, comments, or experiences that they'd like to share. While we're waiting, I'll ask you, can you tell us a little bit more about, you mentioned something about a tool that lets different electronic health records communicate with each other. Can you tell us a little bit more about that?
Sure. In the past, EHRs and vendors, other vendors, used an HF7 interface to create integrations between EHRs and other platforms. And so that used to be very costly. It took a long time. It was really dreaded by the organizations. Now there is what's called API integration. So it's a non-proprietary type integration where, for an example, we monitor multiple organizations' patients for remote monitoring. We're vendor agnostic, so therefore we use different vendors' equipment based on the customer, what the customer wants to do. So we're able to integrate and have the data flow from that vendor's software directly into our software, so our nurses don't have to log onto multiple softwares. Mm-hmm. So it's easier to do. It's much less expensive for integration. So it's just a new way that it's being done. Okay. From a hard link to a soft link.
Mm-hmm. So that would be something where, you know, if we had the geneticist and a cardiologist working on the same patient, they'd be able to see the same records? Would that work that way?
It could absolutely be set up that way, yes.
Great.
Yep, the capability is absolutely out there, yes.
Looks like we have a question. Okay, the question is, what is your most successful model and how has it improved outcomes? So I think this is a question, Bonnie, about your experiences with your company.
Sure, I'll be glad to talk about that. The most successful, well, I've had 2 very successful published companies. I work with a federally qualified health center who is taking care of uninsured, underinsured Medicaid patient populations in rural Eastern North Carolina. and we were able to monitor those patients for 6 months with remote patient monitoring. And what we found, actually just had to finish a PowerPoint on that. I could pull that up. During the 3-year program that we had, we were able to reduce hospital readmissions by 76%, and there was a statistically significant reduction in healthcare costs. The hospital charges prior to remote monitoring on those patients was $1.34 million, and the charges during remote patient monitoring was $121,000, and that's a $1.2 million reduction in every 6 months. Secondly, I work with Vidant Health, which is located in eastern North Carolina. They have a medical tertiary care center and 8 rural hospitals. I implemented a program of 700 sets of equipment. In the first year, we enrolled 1,323 patients, and 683 of those patients completed 3 months of monitoring. We're off the program for 3 months so that we could pull data. Those 683 patients, 3 months before telehealth, experienced 820 hospitalizations. So 3 months during telehealth, it reduced to 270. So that was a 67% reduction in hospitalization. We experienced a 68% reduction in bed days, which is great for Medicare patient populations. And in our less than 30-day hospital readmission rate, we had a control group, which were patients who were eligible had heart failure, were eligible for the program, consented for the program, but once they got home, they refused. Versus patients who, with the same eligibility, they completed the program. The less than 30-day readmission for heart failure patients for the patients who refused the program was 28%. For the patients who received remote monitoring, the less than 30-day hospitalization was 7%. So that was a 21% reduction. We are currently working with an organization to do video visits for pre-employment screening. We've been using equipment, video visits direct to consumer for patients with cancer. So I really say the greatest barriers are lack of imagination and how you can use this day and age, because the prices are down and your capabilities are the greatest now they've ever been.
Yeah.
And I have links to some studies on my website, Elisa.
Great.
That you're welcome to share.
Looks like we have another question. How much of your telehealth service experience has been with pediatric patients?
The only pediatric experience I personally have is we implemented a teleschool program for asthma kids. We were in elementary schools and 5 schools in eastern North Carolina, where we were able to place an audio-video remote monitoring device, and the kids with asthma were able to go to the nursing office and actually do their peak flow inhaler. Well, we do a live video visit. We could see what their peak flow was. We were able to take a picture of that. We also could auscultate their lungs, and we also had an asthma action plan, so that the nurses at their end, the parents had the asthma action plan as well as ourselves. I have never done this, wanted to do this when I was years ago, but it was just too expensive, is for video visits with moms and dads and babies who have just been released from NICU. I mean, there's just so many applications. Anything that you can do video, you can really can reach out and touch.
Great. anybody else have questions for Bonnie about her experiences or your own experiences that you'd like to share, or your own successes that you think would be useful to other people? Oh, looks like we just got another one. Okay. So this says, many genetic counselors are only involved with telemedicine at a single point and not with regards to total continuum of care. If I had to think of one challenge, I would have to say non-compliance with keeping appointments or scheduling in the first place. Any advice? So thoughts about, I know you mentioned a little bit earlier, Bonnie, about appointment scheduling. Any thoughts about that?
Well, I think I would have to look into if they're not keeping their appointments. Is it location? Is it financial? Is it, what's causing that non-compliance? Because what I've found over the years, and I used to say this all the time when I was an inpatient nurse in cardiac intensive care, the same patients would come in over and over again, and I couldn't understand why. But getting into homes and knowing these patients, those that have financial and transportation issues or no support, they're very proud people, and a lot of times will not admit that. So I'd first want to know what's the reason for the non-compliance. And if it is one of those things, then can this be done in the convenience of their home? Yep. Which may make a huge difference, being able to get compliance up.
Mm-hmm. Yep. Yeah, it's definitely
I know that wasn't a direct answer, but
no, I think it is. I mean, I think the concept that, one of the reasons that we're looking to telemedicine is to remove some of those barriers, and I think that in removing barriers, you're going to improve your compliance rate and reduce your no-shows and all those things. So I think they really do go hand in hand. I think a lot of telehealth programs probably do see, better attendance because, you're trying to help your patients remove or reduce as many of those barriers as we can.
Absolutely.
Let's see if I got anything else. Oh, okay. Let's see. Okay, this says, any advice on how to evaluate a patient's experience with the telemedicine through survey or a follow-up call? So do you have any experience with sort of evaluating after the fact people's experiences with telemedicine?
Absolutely. If you go to the American Telemedicine Association's website under resources, years ago I chaired a group and we developed an item bank of patient satisfaction questions that can be used to evaluate your program. So that would be my first place that I would recommend that you go, so you don't have to reinvent the wheel.
Yep.
And two, if you don't find what you need there, if you call the American Telemedicine Association, they will make sure they connect you with some resources.
Great. All right. Let's see. A follow-up to that last question was, do you feel that in doing that type of evaluation, is a phone call more effective than a survey? So is a phone call interview, do you think, more effective than a survey in looking at how your telemedicine program is doing?
Well, I think the most important thing there is who is doing the survey. If I have my nurses doing calls to patients and doing surveys about their care of the patient, then that's not effective because patients aren't going to be truthful to her.
Right.
Yeah, so it really depends upon, you never want the person providing the service to conduct the survey. I know at Guided Health, we utilize our administrative assistant to do the surveys. So we developed the surveys based off questions on the item bank from the HEA, and then we had our administrative assistant call as a follow-up post-discharge.
Yep. That makes sense. see if we have any more. Anybody else have their own experiences they'd like to share of how they've handled some of these care coordination issues? I wonder, Bonnie, do you have any experience in the past with getting multiple, like how do you bring together people in multiple hospital systems to sort of make these bridges between, so if it's just the genetics department, for example, that's interested in bridging hospital A and hospital B, have you ever had experiences with how difficult it is to convince the hospital system to build that bridge for them? I wonder if you need more buy-in from other departments for something like that.
Well, when you say build that bridge, are you talking about the integration, or are you talking about, okay.
Yeah,
well,
mostly the integration.
Yeah, I think way before those conversations are getting together a core group who could be a steering committee, 8 to 10. I know the state of North Carolina, we're getting ready to do this with help with Kathy Wibberly from Matrix, where we're pulling together 8 to 10 committees, chairs. We're going to be looking at all of the needs assessments that have been conducted by the state to see if there's common area where in relation to telehealth that would be beneficial for urban as well as rural areas, and then bringing together people to do an all-day strategic plan and have an initiative. And then once you get that last level of buy-in, you've got to determine not only, you know, what hospital has what infrastructure, and the ones that have infrastructure, can they continue to use it? Those that don't have infrastructure, would they benefit from a video platform that could do all the other things to more centralized and a much more sharing community of documents, tests, etc. So I think that's further down the line. Once you have the other, when you talk about API integration, it's much, the IT department doesn't go crazy like they used to when you said HL7 interface.
Yeah, yep. Yeah, the technology is definitely changing significantly. It should be making things easier for us. Okay, we have another question. Someone says, I was interested in your project with the Federally Qualified Health Center. How hard was it to convince them to integrate a telemonitoring program, and how open were they, or did you have to do a lot of educating?
Well, as far as the providers and getting their buy-in, I strategically targeted the provider who actually was the oldest in the practice at the time. He was 78 or maybe 77 then. Who didn't like anything, didn't want change, didn't want EHR, you know, who really was against it. But I had a good working relationship with him. And when I did this at Biden, I found a cardiologist that I had a long-standing good relationship with. And I started with one individual at each place and said, let's try it. Give me a chance to demonstrate that this works. Because I'd already convinced the organization, FQHC, to move forward. And so we really started with a doc who had respect for me as a nurse, and I had respect for them as a physician. I knew if I got them on board, everybody else would follow. And so that's how I've done it every time, is to find somebody you've got a really good relationship with, and that may not be initially your greatest supporter. Like when I was at a home health agency, I ended up being my greatest supporter of the program was our marketing person. And in the beginning, he was completely against all of it. This is going to generate revenue. This is going to be disruptive. But having him as part of that team, he began to hear the stories of patients and see the outcomes, and so his whole attitude changed to where he started actually approaching payers about reimbursement. So I always like to have a non-traditional person on your group, because if you can, that you have a good working respect for. And then you can have good, honest, open dialogue, and then get the outcomes and move from there.
Mm-hmm. Sort of let the outcomes speak for themselves.
Exactly.
Let's see. Anyone else with experiences they want to share? I'm sort of looking back through your barriers to think about our own experiences. Can you tell us about any experiences you've had with using these systems to provide or allow for provider-to-provider education? I know you and I had sort of talked about that sometimes as something that we face as a need.
Well, I think that it's the same principles that you would use for telecommunications. The difference is with some of these newer platforms, you're not going to spend tens of thousands of dollars on video equipment that you don't need now. You really just need software on your tablet or your computer, to be able, and you can connect multiple people. So it's not just having direct one person to another. It could be multiple people that come in on that to provide education. You can download PowerPoint presentations, educational content, etc. So again, it's just being creative and looking at what are some ways now that you can do this without spending the tens of thousands of dollars you would have had to spend even 3 years ago to do this.
Yep. Right. I'm wondering also if we talked a little bit today about these patient-centered healthcare plans. Do you feel like in the general healthcare system that patient-centered healthcare plans are becoming more common as more people use telemedicine? Like, do you feel like they're easier to implement when you have telemedicine as a tool?
Well, I don't think telehealth or telemedicine as a tool it will assist with the care plan. Again, it's there's very few EHRs that I'm aware of to date that have patient-centered care plans in their system, okay? So it's finding software to be able to do that across the whole system instead of one organization developing their own care plan and somebody else developing their own care plan. You need one that can be assessed in a HIPAA-secure environment and adjusted in a HIPAA-secure environment and evaluated. And that would meet your needs.
Yep. Yep. I'm just writing some of these answers down so I'll be able to share them with people after the fact.
Yeah.
I think that sort of one of my remaining observations or concerns is that I think it's still kind of a leap for some people to think about going from the traditional telemedicine as they've seen it and as they practice it, where it's sort of a hospital to another medical facility, whether it's an outpatient center or another doctor's office or whatever it is, to make that leap from that to a home visit. I'm just wondering what your experience has been over time in convincing people to try it, that's a worthwhile thing to try, both to benefit the patients and that it'll have good outcomes for the healthcare system too.
Well, I think go to the literature and and I can help you, with that. But go to the literature. I mean, this has been around for a very long time, and there's a lot of data that's out there, and that proves efficacy and cost savings. And there's a lot of states that reimburse for Medicaid visits using telemedicine. They have not included the home as criteria yet, but I would recommend going to the literature, and then for the skeptics, perhaps having a webinar of someone, myself or others that Kathy could recommend for you, to do a webinar to start some conversations, do some marketing things. But I think that's the key, because when you're talking to doctors, they want to know what studies have been done and how do I know this works. And we're in a day and age we have that now.
Yeah. Great. Great. Let's see, we might have just gotten. Okay, I think we have another question. Okay, so this says, New York telemedicine law says, with the exception of remote patient monitoring, New York Medicaid coverage requires the patient to be located at a qualifying originating site, like a hospital or other facility. Medicaid covers remote patient monitoring at the patient's home. How does that reconcile with genetic counseling, if you know? So I think, they were sort of asking, you may not know New York State reimbursement issues, but they're saying that in New York State there are some requirements for where the patient is located that would limit the ability to do in-home services.
I believe, I'm not positive, haven't read about New York's legislation lately, but I know somebody that is very well aware, Lexi Silver, and I can get you her contact information. What I believe to be true is home health in New York City, there's reimbursement for remote patient monitoring if it's conducted within a home health agency. I don't think there's any other language regarding home, but if you want Lexi Silver's contact information, she had worked at the state level in New York on reimbursement issues, so she would be a good contact for you.
Okay. But your experience has been that applies to remote monitoring, but do you have a sense of if the rules are different for consultation that does not involve remote monitoring?
Yeah. I don't know the legislation. Okay. That's why I think Alexis would be a better person for you to speak with, or either Kathy.
Okay. Yep. Yeah, I know both I think the American Telemedicine site as well as our regional telemedicine group on their website, I think they both have a lot about the laws with regard to parity and all those types of things. So that might be a good place to explore what the law says with regard to what the actual requirements are to be required to be covered under parity.
Right.
All right, let me check and see if we got any more. All right. Well, I think that was our last question. So I want to say thank you so much to Bonnie. I think we all learned a lot about possible solutions to our care coordination challenges. As I said, notes and the recorded webinar will be posted in Basecamp, and the next webinar will be December 13th about needs assessment. Please let us know if you have any questions or comments, and feel free to continue discussions or ask each other questions in Basecamp. I thank you all for your time, and thanks again to Bonnie.
Thank you so much. I appreciate it.
Okay. Bye-bye, everyone.
All right. Bye-bye.